Good
morning, members. We can call our meeting to order. First of all, let's get the team from the government to join us. On the 31st of March, we raised a number of questions. Again, on the 14th of April, we also raised some questions. We have got two papers carrying the response from the administration. So, CB bracket 2 1321/14 to 15 bracket 01 as well as CB bracket 2 1321/14 to 15 bracket 03. Once the public officers are ready, please walk us through the two papers. What about the paper from the Privacy Commissioner? I think has been circulated to members, and the legal advisor has asked for the guidance note from the Office of the Privacy Commissioner for personal data on personal data protection in cross-border data transfer. You'll find it in paper CB bracket 21321/14 to 15 bracket 04. I think in a moment the legal advisor can also tell us more about that paper. But then, first of all, Mr. Chen, please walk us through the two papers from the admin. 1321/1415 bracket 01 as well as bracket 03. First of all, the first paper. Last time we gave our response to issues A and B, so we're now on items C, D, and E. The electronic health records may be used for research and statistics. A member talked about the Hong Kong Alliance for Rare Diseases. The member would like to know whether we have ever consulted the views of the alliance and whether the alliance is in objection or not. We went back to look up our record. There was a public consultation between late 2011 and early 2012. We don't have any views from that alliance. But then for the 2015 policy address and the 2015-16 budget, the alliance gave its views on the healthcare policies of the government. If I may refer you to paragraph 2, it says that they would like to recommend the establishment of an integrated and comprehensive rare diseases registry to facilitate research activities involving patients with rare diseases. The alliance considered that the registry would serve essentially as a repository of past rare disease cases with regular updates in order to inform and facilitate proper diagnosis and treatment. So for us to set up such a database, we have to make use of the past electronic health records of the relevant patients. So we looked up our record and we've given our reply in the paper. Ms. Emily Lau. At that time, I was involved in raising this question. I'm grateful to the government for liaising with the alliance. Now, we've been told that there was a consultation between 2011 and 2012. Probably the alliance had already been set up back then. We organized joint activities with the alliance. They are concerned about this matter. I can appreciate their recommendation. This is also in line with the government's position. But then we are concerned about the privacy concerns. We don't object to the collection of data, but then we must make sure that this is being done without intruding into the privacy of the patients. In particular, for rare diseases, sometimes we've only got just a couple of patients suffering from a particular rare diseases. So we want to know whether they will thus become identifiable. So the alliance may or may not know about the bill. So perhaps you can tell them that at a Bills Committee meeting, members would like to get their views and ask the alliance to tell the LegCo what you think, and if they are happy with it, so be it. I think this alliance is relevant to this matter because rare diseases are rare diseases. We don't want them to come back to voice their objection after the bill has been enacted. I know they are quite limited in resources, so I just wondered if the government can take the initiative to approach the alliance. Mr. Chen, we are fine with the idea. We can liaise with the alliance to tell them that whether they have no objection to the use of electronic health records for research and statistics, and we'll ask them if they have got any recommendations so that their members, their patients can be afforded extra protection. Yes, please send us a copy of your email so that we know what you have done, and let's wait for a reply from them if there is one. Mr. Chen, item D. The assistant legal advisor said that at a public hearing, there was one deputation who expressed his concern, namely that even though anonymized data would be provided, we still cannot assume that it will be privacy safe. We do not disagree with this view, and we won't say that even in the case of anonymized data, the data can never be re-identified. We don't rule out the possibility. When the deputation made this point, I think towards the latter part of his deputation, he was saying that anonymized data could not be assumed to be privacy safe. He said that we must review the matter to make sure that it would be safe enough. We totally agree that this should be done. In paragraphs 4 and 5, we've set out our answer. When we provide the non-identifiable data, it doesn't mean that we're happy with just deleting the name. We'll try our best to de-identify the records. In paragraph 5, maybe more can be done. Say, for example, we try to use a range instead of being very specific or precise. Say, for example, giving an age or age group instead of the exact date of birth, district of residence instead of detailed residential address of individual patients, or a year of admission instead of a specific date of admission. We believe that by using this approach, we'll be moving in the same direction as that deputation. That is, every time when we provide the non-identifiable data, we do go through a vigorous process to make sure that we'll try to be as safe as possible. So in this regard, we do see eye to eye with him. And then in the case of DNA, it is said that by providing DNA data, the data can still be identified because DNA is unique. However, for our electronic health records, for the first stage, for the 9 items to be included, it will not include DNA data. Mr. Chen, if I may ask a follow-up question on behalf of this deputation. Of course, the deputation involved was Professor Bacon-Sean, as to who will make the decision. Now you say that you won't assume that by deleting the name it is tantamount to making it totally privacy safe. You try to find out whether more should be done to make sure that the data will not be identifiable. So anything that's nothing to do with the research will be sort of removed. Who will take care of this? Say, for example, I may be a researcher. For the sake of convenience, I may try to ask for everything to be provided. So who will be the gatekeeper? Who will decide what will be given and what will not? Will it be the government who will make the administrative decision? Our current thinking is that, now say for example, a researcher may come forward to ask for identifiable or non-identifiable data for the sake of research. Now, when they make an application to us, if we don't need to provide identifiable data, etc., then it will be up to the office to grant the approval. When we do give the approval, we can impose certain requirements. We will be careful in striking a balance as to what extra conditions will be imposed on the researcher. And for the data to be provided, as I have said, sometimes the data may not have particular elements, but we still have to be sure that whether it will certainly be non-identifiable to the researcher. We will go through the process together with the hospital authority. As to the request to have data containing the personal information of patients, we will of course be even stricter, and then will of course be impose certain conditions, so there will be a filtering process. Now, your office will be responsible for giving approval. Will there be some guidelines? Be they internal only? And what about the hospital authority? Do you already have similar guidelines that can be adopted in the future or good for reference? As you have said, you'll be very cautious, but then we want to know how cautious you will be. Do you have current practice that you can sort of instill confidence in us? Thank you, Mr. Chairman. We still have one piece of homework outstanding. At a previous meeting, when we were looking at similar provisions, a member raised similar questions. Even without the system proposed, there are already research requests for information to be given. So the member asked whether we have criteria for giving approval available for members' reference. We promised to gather the information. We're still collating the information.
50.
When we come to clause 52 or 53 of the bill, we will discuss the composition of the committee, and then we can give you the relevant information for reference so that you know at present when you request for data access with from the HA, what criteria will be used to consider the application. Clause 50 what? I just want to jot it down. 53. The setting up of or establishment of the research committee and the functions. So when we come to that, we will explain to members about this establishment of the board, the EHR Research Board, and the function. Well, on the 18th of March, now a member of the public expressed some views on the EHR Research Board, and I just cite from the submission that when we discuss clause 53 and 54, we should ask the government to give to answer his question. That is from Professor John Bacon-Shawn.
To elaborate on the specific requirements for the 10 non-official members of the EHR Research Board, but the details are absent as of now, and it is unclear whether this will be properly addressed. So
I think the assumption is that when we come to clause 53 and 54, please give us the information in detail. Yes, Professor Bacon-Shawn's concern is about the composition of the board and the membership. So we will by then give you more details on the composition of the board and the relevant requirements. Any other questions on point D? If not, then Mr. Chan, you may continue with point E. Well, last time a member asked, say in the event of an incident, what legal liabilities are involved. And last time we gave a verbal reply, and we just put down in writing the legal liabilities of different parties. Now, when an incident occurred, we need to consider the circumstances and the facts involved in determining liability. However, in an event, if the complainant believes that his interest has been undermined, then we are talking about the content of the e-health record. And in fact, the content is not contributed by the Commissioner for the e-health record, but by healthcare providers such as dental clinics or medical clinics as a result of the record prepared by these clinics. So the accuracy of the data would depend on the medical professional compiling that record. And the Commissioner for the e-health record is the system administrator or the operator of the system. And the responsibility, therefore, is to ensure that the data entered in the system would accurately be referred to the patient, or that the formatting should be accurate. And that's the responsibility of the operator or the system administrator. And if there is a complaint, the plaintiff would need to make it clear whether the error is due to the source of the data or a system error. If it is a system error, then the liability would be on the part of the Commissioner. Otherwise, it would be on the part of the healthcare provider. Any other questions from members on this? If not, we can move on to the other paper. 03 1321/1415(03). Now, the paper 03 sets out the issues that we are following up on from the discussion at the meeting on the 14th of April. Now, first of all, in relation to the wording in Hong Kong in the number of definitions of terms, last time we discussed whether the term in Hong Kong was necessary. And let me reiterate that there are several provisions containing the word in Hong Kong. First of all, for a private clinic or healthcare provider, which applies for registration with the system, there should be a service location in Hong Kong for the HCP to be eligible for registration. So this first point is related to the service locations of HCPs. Secondly, the person accessing this record should be somebody apart from a healthcare recipient or healthcare provider. The person has to be a healthcare professional registered under the relevant ordinances in Hong Kong. And point number 3, as for the definition of healthcare service, the definition is that it has to be for an activity performed in Hong Kong. And last time we explained at the meeting that we have included the words in Hong Kong in these 3 provisions so as to enhance our capability to take follow-up action in the event of incidents. So say if the HCP is registered in Hong Kong, we can take follow-up action. The same applies to the medical professional, and we can take follow-up action in these cases. As for point number 3, that the activity should be performed in Hong Kong, we considered that geographically, after accessing the record, the HCP will then give treatment to the HCR in Hong Kong. But last time we mentioned a scenario that let's say if the person is away from Hong Kong, say in Canada, and if the person is to receive such an activity outside of Hong Kong, then the doctor accessing the data will be breaching the provision because it would be for an activity not performed in Hong Kong. And that is why we find it necessary to include the words in Hong Kong. And having reviewed or looked into the suggestion, in the interest of the healthcare recipients, we believe that even after deleting the words in Hong Kong, there will still be adequate protection for us to take effective follow-up action on breaches, because we still have the previous 2 points, that is the healthcare provider should be registered in Hong Kong and the service location should be in Hong Kong. And that is why, based on that suggestion, we're going to amend point number 3, as you can see in Annex A, which includes both the Chinese and English version. So this is following the member's suggestion. Any questions from members? Do we need to read through these 2 provisions? I think we have gone through that before. So do we need to read through these 2 again? Legal advisor? Any questions? Anything to add? Thank you, Chairman. Now maybe at this juncture I will inform members of a number of points. You may recall that for this bill, there are no clear stipulations that the HCP must be registered in Hong Kong, and that is, they should be allowed to access the e-health record overseas. And our consideration is that if the HCP improperly access the EHR, whether the commissioner will be able to regulate over this in the bill, because there is no extraterrestrial jurisdiction of this bill, and there is also another question on practicing medicine outside Hong Kong. And according to the Background brief. I considered the object of the bill, and according to the government, the object is to set up the EHR sharing platform for connecting the participating public and private hospitals, and that is about the connection between public and private hospitals, and so that's within Hong Kong. And the second object is to make electronic medical record or e-patient record systems, so that's about the software. And the third object, to formulate the legal framework to protect data privacy and system security. So it seems that among the three objectives, none is about facilitating doctors in practicing medicine such that wherever they are, they could still have access to the patient's records. So I think members should consider the priorities, and members may wish to refer to clause 12(6) on consent or sharing consent. Now, for a prescribed health care provider, the consent is to provide to the system any shareable data of the healthcare recipient, and to obtain any shareable data of the healthcare recipient, and also to provide to a referral healthcare provider any shareable data of the healthcare recipient relevant to the healthcare referral. And as for the service locations of healthcare providers, they must be registered in Hong Kong. So what I covered relates to activities happening in Hong Kong, not outside Hong Kong. However, the problem is that as for the HCP as an individual, because they can leave the territory, and when they find it necessary, they can, or if they find it necessary to access the health records with a laptop, which may fall outside the functions as mentioned in the bill, how would the Commissioner follow up on these cases? If we read clause 26, we can see that they may use the data for a very wide scope of purposes. That is, the data and information contained in the e-health record of a registered healthcare recipient may be used for improving the efficiency, quality, continuity, or integration of the healthcare provided. So compared to the privacy law on exemption, on medical grounds, or on emergency cases, this covers a much wider scope. And just now, Chairman mentioned a guidance note issued in December by the Privacy Commissioner, which is a guidance on personal data protection in cross-border data transfer. And we understand that Section 33 of the PDPO prohibits the transfer of personal data to places outside Hong Kong. So there is a prohibition on the transfer of data to places outside Hong Kong, save in some circumstances. Now, Section 33 is not yet effective. However, it is recommended by the Office of the Privacy Commissioner that the guidance should be followed as part of the corporate governance responsibility to protect personal data. So be it the hospital authority or Department of Health or healthcare providers as data users, this sets out the respective liabilities.
Please turn to page 4 of the guidance note. It is found in paper CB bracket 21321/14-15 bracket 04. This is the paper. The commissioner has given information about some exceptional scenarios, say for example, written consent. We may transfer your name and contact details outside Hong Kong to agents where there may not be in place data protection laws which are substantially similar to or serve the same purposes as the Personal Data Privacy Ordinance. That means your personal data may not be protected to the same or similar level in Hong Kong. Please indicate your consent by ticking the box below. So you'll find it on page 5 of the English version. So there is a box for you to put a tick which indicates your consent to the transfer of your personal data outside Hong Kong. Before we give consent, we have to be satisfied that, first of all, the data will be transferred to a place outside of Hong Kong where there may not be privacy protection, and yet you are giving written consent to allow this to happen. And with that consent, then the data user may collect your personal data. Earlier on, we have already referred to exceptions, that is on health ground or in the case of emergency. If I may also, if Mr. Leung doesn't mind, I may also want to follow up on what the Assistant Legal Advisor has said. We haven't got the Commissioner on Privacy here. Now, the Legal Advisor is concerned that if for the sake of expediency, and if we allow access to such data, she's concerned as to whether this will be problematic. It is unfortunate that we haven't got the Commissioner with us, the Privacy Commissioner here. Having access to such information, will it constitute transfer? Because the data is still in Hong Kong, but then the access takes place outside Hong Kong. What about employees of an overseas office downloading the information? I don't know how the Commissioner will see a case of downloading. I assume that we are talking about the same healthcare provider, but then he may be overseas. He would like to access the database to have a look. So will this constitute downloading? Will it be regarded as data transfer? I'm not sure whether we need to confirm with the Privacy Commissioner. Of course, we will say that Section 33 is not yet effective. It is, after all, a guidance note only, but we will still be interested in the extent of the requirement. Dr. Leung, electronic health record has one advantage, that is, you can access the information overseas. We've got many patients who are residing on the mainland. Now, as long as the healthcare provider has a registered address in Hong Kong, then I think the healthcare provider should be allowed to access the data anywhere, whether in Hong Kong or outside Hong Kong. But now that we are on this topic, Now, we may have a patient retiring on in a place on the mainland, and we may have a medical doctor taking care of such a patient who is in the mainland. There is a case for the provider to have access to such data. Now, I don't think the bill is meant to facilitate the provision of health care by a provider, but then in this case, the interests of the doctor and the patient will be aligned. If it is not facilitated, then fewer people will be interested to use it. If it is more facilitating, then more will be attracted to use the system. My point is, I don't think we should restrict the use of the system geographically. As you know, that more and more people are living on the mainland and working on the mainland. You say that the HCP healthcare provider must have a registered address in Hong Kong. It doesn't pose a difficulty because if someone is qualified, he can still get registered and have a registered address here. Now, if we have a mainland patient, if he is in need of some medical service, if we have a Hong Kong doctor seeing him, of course it will be good. But if that is not done, if that cannot be done, can a mainland healthcare provider see this patient? If the recipient has already given consent, but then you say that the healthcare provider is not a registered professional in Hong Kong, and so he cannot have access to the data. Of course, on the other hand, not every Hong Kong doctor is registered on the mainland. Say, for example, I may not be able to practice on the mainland. Well, of course, I may be given a license by that particular body. So perhaps we should think whether we should mandate registration locally before you can have access to the data. Mr. Chen, your legal advisor and Dr. Leung have raised a few points. I try to answer in one go. I think Dr. Leung's understanding is correct. The bill as it stands only requires the HCP, that is the private clinic or the private hospital, at the time of application must give an address in Hong Kong for providing service for employees of the provider. They must be locally registered healthcare professionals. As to the act itself, we don't confine it to take place in Hong Kong only. Say, for example, we may have a Hong Kong doctor of the Hong Kong Baptist Hospital. He has a notebook with him. He's in Canada. He would like to look up the record of his patient. That's fine. He can do so when he's in Shanghai. The bill doesn't say that he can't do it. So whether he's in Shanghai or in Canada, as long as he can meet the two aforementioned conditions, he works for a HCP and he is a registered professional, then he may do so. Now, the purpose of having access to the data is to provide healthcare service. We have said that it should be healthcare in Hong Kong only. But then, of course, for the sake of patients, the patient may encounter an accident or suffer from a disease while in Canada or Shanghai. And so we have agreed to take out the words in Hong Kong. But we don't think that we need to worry, because when we talk about the well-being of the patient, we have to talk about the physical well-being of the patient, and on the other hand, we want to protect his personal data, whether it will be lost or whether it will be leaked. Now, of course, when we take out the words in Hong Kong, and then the healthcare service may take place in Canada or in Shanghai, but then we're still talking about healthcare provider in Hong Kong, like a clinic or hospital, and a registered professional thereunder. So if we want to hold anybody liable, we can still find that clinic, hospital, or professional liable. We can go after the organization, or we can go after the individual for professional misconduct. So when the well-being of the patient is jeopardized, like his physical health or his privacy, then I think we are protected. Now, if it is said that healthcare service has to be provided to a patient in Shanghai, in Shenzhen, or in Canada, I think there is a case. Other than protecting his physical well-being, we also want to be privacy safe. Therefore, we are still talking about a Hong Kong registered healthcare professional. We may very well have a HCP with a branch in Singapore. As to whether a doctor and nurse in Singapore can access the data, according to our bill, no, that can't be done, because we want to make sure that we can still enforce the law in the case of an untoward event. So we have 3 tiers here. First of all, the HCP, the organization. Second, the healthcare professional. And thirdly, the place where the service takes place. For the first 2, we insist that it must be in Hong Kong. For the third, for the sake of the well-being of the patient, we can waive that. It seems that the legal advisor would like to know whether we are going against the original spirit of the bill. Now, the purpose of setting up the system is to have a sharing platform for connecting the public and the private hospitals. We are not encouraging it. We are not imposing it. We are simply saying that a doctor in Canada reading up the record will not be breaching the law. That won't become an objective of the system. Now, we have been told that Section 33 of the PDPO should be drawn to our attention. I have to say that I'm a layman about personal data. Like other laws in Hong Kong, we will be abiding by the Personal Data Privacy Ordinance. I've repeated our commitment many times, unless we are saying that we should be exempted from a particular provision. Otherwise, it should be assumed that we are following the rules and regulations. Once Section 33 comes into effect, we'll certainly be following it. And in fact, I have read our bill, and I don't think any of the provisions will go against Section 33. So even when Section 33 comes into effect, I don't think anything in the bill will render us breaking the law. As to the third point, it goes beyond my portfolio, but I still want to say a few words. I don't think Section 33 is banning the use of data outside Hong Kong, because it has said that unless the conditions are met, and then you have 6 paragraphs. If you meet one of the conditions, then there can be cross-border data transfer. And he has also designed a form. And under subsection A, the Privacy Commissioner will be examining the different institutions around the world, and then he'll be publishing a list setting out the places which he is happy with their laws in force. And if the data subject has given written consent, again the transfer is fine. As for E and F,
they're about exemptions, for example, on health grounds or during emergencies. So Section 33 prohibits transfer of data to a place outside Hong Kong. However, it comes with a condition, and that transfer may be possible if the following conditions are met. So I don't think our bill is in any way a contravention of this section. Now, just now, we also discussed this. It's hard for the sections or for the provisions to become effective even for after a decade. That's because of the difficulty in providing definitions, and they also cite examples. So I think they must really improve the provisions before they take effect. And still, even if they take effect, if it takes effect now, we can still comply with it. And our bill is not on Section 33 of the PDPO. So we should focus on our part, and that is whether the bill is contravening the PDPO as it is now. And I don't think this is the case, and it is not contravening Section 33 either. Dr. Leung Ka-Lau, followed by a number of members. I want to clarify one point. For healthcare professionals registered in Hong Kong, well, my understanding was that whether an organization can register itself as an HCP depends on whether the organization has healthcare professionals as set out in the schedule. However, I seem to recollect that there is no requirement on the data access being made by the healthcare professionals themselves. I mean, for registration's purpose, the HCP must have somebody who is a registered healthcare professional. However, it doesn't say that it can only be, the data can only be accessed by the healthcare professional. Well, in future, we'll see whether the healthcare professional is one of the 13 categories of healthcare professionals in Hong Kong. However, does it say so in the law that only a registered healthcare professional can access the data? You have this schedule which says that the HCP can be registered as an HCP if it employs one of the following healthcare professionals. But it doesn't say that the data access can only be made by the professional, because in a healthcare organization, they employ a lot of people, and even a clerk could access the data. So what I'm saying is that it seems that the bill doesn't say that only a healthcare professional can access the data, as he said it just now. Let Mr. Chen clarify. Well, at previous meetings, other members also raised a similar concern. If the person is not one of the 13 categories of healthcare professionals, how can we make sure that access could only be made on a need-to-know basis? Say, if I'm a security guard or an accountant of that organization, why should I be given the right to access the data? And we must emphasize the need-to-know principle. And that is why, to address members' concerns, we have included 35A. That is the next clause we will be scrutinizing, that data can only be accessed by a relevant healthcare professional in relation to the HCR he is treating. And that is to address members' concerns by providing 35A for preventing a non-healthcare professional in accessing the data. I think you are mixing the two things up. Well, when we talked about the need-to-know basis, we were concerned about non-healthcare professionals accessing the data. But Dr. Leung's concern is this. maybe a doctor who is not locally registered may access the data. So I think he may think that the doctor has the need to know, but he is not under that healthcare provider. But from a doctor's perspective, it may be best for the doctor to have direct access of the data. But my question is whether each would come in an account, so with a login name. So I think this is universal. You must not pass your own login name and password to another person. So unless the doctor is somebody qualified in Hong Kong who lends his account to another healthcare professional overseas to access the record. I don't know whether this will be contravening your code, but there is nothing that says that the data cannot be, this information cannot be passed on to another individual. When we talk about the interest, we're talking about two matters, the well-being of the healthcare recipient and the privacy of the patient. Now, we're tightening up the rule by providing that the HCP should be registered in Hong Kong, because for a healthcare provider with branches in Shanghai and in overseas, it may fulfill the first criterion, that is to have a service location in Hong Kong. However, if they then employ a Canadian doctor, then there is nothing to stop the Canadian doctor from accessing the record, and that is not what we want. For the other point you mentioned, that is about an HCP with a service location in Hong Kong with different employees, and you may not wish a non-healthcare professional without the need to know to have access of the record, and that would depend on the administrative code. When I think Mr. Chen has now made it clear the issue, so we need to provide clearly in the bill so as to not being criticized by patients. Say, for example, in Nepal, healthcare professionals may wish to access the record for emergency. And I want to thank our legal advisor and the secretariat for their work, and I agree with Dr. Leung Ka-Lau on his point of facilitating the doctor's work. I think apart from the public's interest, we also need to consider the patient's interest. Now, if a patient is injured, if there is a family member of yours injured overseas, they may wish to do something about that, and they may wish to have access of the patient's medical record. Now, perhaps we could ask the Privacy Commissioner on matters relating to privacy, because the section is not yet effective. And on the other hand, we need to consider our stance. On the one hand, we are concerned about abuse of data. Now, on the other hand, I support it. I think this is useful, because sometimes when you switch from one doctor to another, it will be a waste of time if you need to go through the examination and diagnosis again. So if something happens to a patient outside of Hong Kong, he or she may need to receive treatment, and this person may come under a coma, and he may not be able to say that he consents to the transfer of data. So what should be done about that? Because Hong Kong people like to travel, and sometimes unfortunate things happen, and we really want this system to be able to help these people. So would Mr. Chen please explain to us whether you're concerned about abuse of data, and as mentioned just now, if a healthcare professional is not registered in Hong Kong, and if he then gives treatment to a patient in a hospital there, since the doctor that has no right to access data of that patient, he may need to go through the whole treatment process again. Is that the case? Well, let Mr. Chen answer Ms. Emily Lau's question. There are different scenarios, different circumstances. Using, again, the example of a Hong Kong resident having a traffic accident in Canada and being hospitalized in Canada, then if it so happens that a Hong Kong doctor is in Canada by coincidence, then can he retrieve the patient's record using his own computer? Now, last time we proposed this amendment, that is, we're going to delete the words "in Hong Kong" so that the healthcare professional will not be breaching the law. Now we don't yet have this system. So what happens now is that if a Hong Kong resident is hospitalized in Canada, then if that patient is conscious, then the Canadian doctor will ask whether such record is available. If the patient is unconscious, then naturally the hospital will check with the Hong Kong authority whether such record is available, because this Hong Kong resident is now in the hospital. So it's up to the healthcare professional to make this professional judgment whether the data should be released to the Canadian doctor. So that is what happens with or without this system as of now, is for the healthcare professional in Hong Kong to exercise his professional judgment to release his information or data in the interest of the patient. But Chairman, that means the patient's family members play no part in this matter. Well, of course, the present operation is that if the doctor finds it necessary to do so, the data can be released. So there is no protection. The system is quite crude at the moment. But so far you have not received complaints about abuse of patients' data, is that right? It has to do with the privacy law at the moment. So if a doctor now receives a request from the Canadian doctor about a Hong Kong resident in Canada, then it's up to the Hong Kong doctor to exercise his professional judgment whether to release his data or not. Will this amount to a breach of the code of conduct of the medical profession or the privacy law? Then, well, it depends. But there are exceptions given in the guidance note that even without consent, the patient's data can be transferred, and the present situation is that the doctor in Hong Kong can make his own professional judgment. So even if, as a result, data is given to the Canadian doctor, he will not be breaching the law. Will he consult the family members? That means on receiving the Canadian doctor's request, will the Hong Kong doctor ask or consult the family members? Perhaps we should ask the two doctors here. Dr. Wong? The Canadian doctor can contact the Hong Kong doctor directly. Say if the identity of the doctor is known, if it's somebody from HA, then he can. The other avenue is through relatives and friends. If the doctor can be identified, then he can approach the doctor. But it depends on whether this is an emergency situation, whether a third party is involved. Usually, data will not be passed to, say, a family member or a third party. Usually, direct contact should be made to reach the doctor. And secondly, after the system commence operation, say if a Hong Kong resident is unconscious in a Canadian hospital, and if a Canadian doctor or a family member there is aware of an EHR record in Hong Kong, then in principle, in healthcare situation or in emergency situations, then without prior consent of the patient, the healthcare professional can still have access of the data of the patient's record. And even if it's done through a third party, as long as the nature of such data disclosure is to provide emergency health care and in light of safety, such an exemption could be given. And this is also included as part of the functions of the system in future. However, this can only be implemented if the code of conduct is complied with. Anything to add?
They will switch on the mic for you.
About family members, I mean, in general, a family member does not have any right to the medical records of their family unless, you know, it's for minors, that sort of thing. I think the only case would the one that I think you described, where a family member is taken ill somewhere else, and their relatives in Hong Kong maybe are able to contact the doctor directly. The doctor still has the obligation to you know, to make sure that, you know, this is a valid medical emergency, that this relative really is acting on behalf of the patient and all that sort of stuff before releasing information. But I think in general, you would be better served to then release the information directly to the doctor rather than to the family member. I mean, there's all sorts of situations where, you know, you can imagine the family member not acting in the patient's interest and using this as a pretext. So, you know, that's why the doctor would in general not directly release to the family member.
Mr. Chairman, well, if you have a record of the number of times that you have done this, that is a family member falling ill in the overseas, of course we're talking about the hospital authority, so please tell us how many times you have done this. We don't want to pass a bill which would disallow things that are currently being done. The citizens would criticize us, but of course we have to be aware of the risk. So does the hospital authority have such information? I will try. I'm sure this has happened in the past. As to whether the hospital authority has kept separate statistics, I have to check. Yes, please. Just now, Ms. Lau has referred to a particular scenario, and then Dr. Leung also referred to another scenario. In the latter case, it's a matter of HCP has a doctor having his system installed on his computer instead of just any medical provider in Canada, and for that HCP to just surf the internet and go on a particular website. So it must be the case of a doctor in Hong Kong who has taken part in the system, and it so happens that he is there. So it isn't just a matter of visiting a website. It's a matter of having participated in the system. So we talk about someone in Shanghai or Canada. So it isn't a matter of the HCP there being aware of the system in Hong Kong, and they just want to get a password and they try to get a Hong Kong doctor. No, it is not the same. It's a matter of having already installed the software.
There's a series of, apart from the law itself, there's a series of measures that are in place to try and protect the privacy of the patient. So one is the patient has to give explicit consent to the healthcare provider. The other one is this registered healthcare professional, because if we relax that and we say, okay, if it's a doctor in Canada who's not registered in Hong Kong, we have no way of knowing if that's an actual doctor. I mean, that's a major control point, which then it would introduce a major weakness in this whole security model. I think if we wanted to, and it's not I don't have the actual numbers, but it's certainly not the common case where you have to, provide healthcare outside Hong Kong. I think if we had to support that, it'd have to be a new model of access, something that we could, look at in future stages. But the current model really, I can't see how we could do it without a major compromise to the whole security model. So I think we can look at it in the longer run. But it's not the usual case. Certainly it's not the usual case. It may happen, but the vast majority is within Hong Kong.
Okay.
好，張超雄議員。
Dr. Fernando Zhang. Thank you, Mr. Chairman. I don't find it strange if this is to happen on the mainland. Hong Kong U has an ancillary hospital in Shenzhen, and at least we have got 3 homes for the aged sponsored by Hong Kong. And we have got Hong Kong healthcare professionals going there to provide service. So whether we can anticipate more Hong Kong citizens receiving healthcare service on the mainland, and their healthcare records have to be accessed on the mainland from Hong Kong. For countries which have a good record of privacy protection, of course, we are not worried. But then on the mainland, they have got a separate legal system. You can't talk about privacy protection in front of the state. So it's a society where there isn't much protection of personal data and privacy. So I'm worried. Now, you may very well talk about patient consent. I think many patients will think that the state will not be interested in their privacy. This is not surprising. It seems that we are now giving blanket approval or blanket exemption, so that whether they have got anything similar to Hong Kong, insofar as personal data privacy ordinance is concerned, we are still giving approval to have cross-border data transfer, then I see difficulty here. As a patient, if I have got a doctor from Canada or a doctor elsewhere wishing to look up my medical record, I will give consent. But I would not agree to the data to be transferred to the mainland. So I want to know whether I've got an option. And then it appears that so far you have yet to answer the question of the legal advisor. Now, if somebody is to breach the law outside of Hong Kong, are we able to enforce our law? So is there any problems with jurisdiction? It appears to me that the government hasn't come back with a clear answer. 2 questions here, Mr. Chen. For the first question, I think Dr. Zhang is sort of talking about whether Section 33 of the Privacy Personal Data Ordinance will come into effect. Under Section 33, there is a ban on cross-border transfer of data unless one of the 6 conditions can be met. Now, this particular section hasn't come into effect. And among the 6 conditions, for A, it says that the Commissioner will publish a list setting out the places where he is satisfied that there is in force a law which is substantially similar to or serves the same purpose as our ordinance. So even if there is a data transfer, there won't be any breach of the law. But of course, we don't know which countries will be included in the list. It may very well say that certain countries will be listed while others are not. If a country doesn't appear in the list, then you can't rely on Section 33(2)(a) to get exemption. But maybe exemption can be granted by citing one of the 5 remaining. Say, for example, it is for the purpose of emergency or rescue. I won't comment on which country has got good protection for personal data, as the Commissioner hasn't done this. But it's more a job for the Privacy Commissioner than for our side. But as soon as Section 33 comes into effect, we will abide by the law, because we haven't asked for an exclusion from the Personal Data Privacy Ordinance. Dr. Zhang is saying that would it be tantamount to a blanket approval for data transfer? I don't think I can answer on behalf of the Privacy Commissioner. Even if you can meet condition A, I think he's referring to this particular bill. Are you sort of giving blanket permission? Now, our proposal is that we ask the patient to give consent. Then only with consent can the HCP have access to the data. Now, say if this person goes to the mainland, he goes on to the system, he visits the system. Say, for example, a doctor goes to Shanghai or Melbourne, and then the doctor would like to read the data. Is it possible if he doesn't access the information personally? What about if he hands over the data to somebody else? Handing it over to somebody else, of course, is a breach of the law. We have said that there should be 3 tiers of protection. First of all, the HC to be registered in Hong Kong. Second, HC professional registered in Hong Kong. So a locally registered hospital, a locally registered medical doctor or dentist, he may have access to the data while outside of Hong Kong. But of course, he must have with him a computer that's been accredited by us. And don't forget that Section 35(a) to be added will still count. What's the purpose of having access to the data? It is only for the sake of treating the patient. If he would like to have access to the data, but then the person is not his patient or is not for the purpose of treatment, then it is against the law. Mr. Chairman, we may have patients on the mainland. Say, for example, a patient residing in a residential care home for the elderly. I'm not sure whether the Shenzhen Hospital of Hong Kong U is registered on the mainland or in Hong Kong. Well, registered in Shenzhen. Well, in this case, it will not be regarded as a qualified HCP. But if it so happens that we've got a Hong Kong doctor going there and he has with him his notebook, and if there is a need, he can have access to the data. Whether it is Hong Kong U Hospital or some other hospitals, if that hospital hasn't got a place of service in Hong Kong, then it cannot get registered as a HCP in our system. Mr. Chairman, Hong Kong U is Hong Kong U, so clearly it is registered in Hong Kong. But its ancillary hospital is wholly owned by Hong Kong U. So what is the position?
Well, of course, I am not too clear about the details of this hospital, but this hospital must be a locally registered entity. Well, the Hong Kong U may be locally registered, but this doesn't offer much help. Well, normally for Queen Mary Hospital, it is a locally registered hospital. The problem is the doctor may have the respective identities at different hospitals, and the doctor may carry his own notebook, and he may access the record overseas. So I think the problem has more to do with the healthcare professionals than the HCP. Mr. Chan, the HCP cannot register in Hong Kong. Well, first of all, the HCP must have a service location registered in Hong Kong, and a healthcare professional working under this HCP can, with an approved computer, have access to the data. Otherwise, this cannot be done. I think we need more clarification on this. Let's say we have private hospitals in Hong Kong operating a branch in the mainland, like the Hong Kong U Shenzhen Hospital. So they're under the same group. It has a service location in Hong Kong. It is registered in Hong Kong, and it also has a branch in the mainland. It also has healthcare professionals registered in Hong Kong. So will they be qualified to have record of the EHR? Now, when the HCP makes this application, must it be a healthcare organization or healthcare group, or can we have something like a private hospital? For example, for the Hong Kong U Shenzhen Hospital, does it come with a Hong Kong U healthcare organization, or must it be a distinct entity as a hospital? I think I won't use the example of Queen Mary Hospital or the Hong Kong U Shenzhen Hospital. Let's say if we have a hospital called the Admiralty Hospital in Hong Kong, there is a service location. In Shanghai, it has a branch. If the service location in Hong Kong is where the Admiralty Hospital operates, and if it applies for registration, then I will register the Admiralty Hospital as an HCP. As for the 13 categories of healthcare professional registered in Hong Kong working in this HCP, if one of these professionals is in Shanghai and the professional has with him a laptop computer with certain approved software installed to access the data of the patient in Shanghai, then under the present laws, the professional can do so. There is no prohibition. As for whether the activity is performed in Hong Kong or Shanghai, that is another matter. Maybe the professional may engage in a medical act in Shanghai. These are two different things. Point number 2. Well, as I said, the HCP is registered in Hong Kong. The healthcare professional is registered in Hong Kong. Does it mean that the healthcare professional can just casually access the data's e-record in that hospital in Canada or in Shanghai? No, because there is also the principle of need to know to be complied with. So the HCR should be somebody that the professional is giving treatment to, and that is why we are proposing clause 35A as well, to impose an extra condition. Although you're a registered doctor in Admiralty Hospital, even if you're in Shanghai, you can access the e-record. No, because we need to comply with 35A as well. So let's say if he breaches 35A, meaning that he doesn't have the need to know, then for other purposes the professional inspects the patient's record, then does this bill regulate this situation? Well, let's say if this really happens, the healthcare professional accesses the record of a patient he's not giving treatment to, we can take follow-up action on the HCP, that is the Admiralty Hospital. That is, as a healthcare provider, he has the liability because he must take the provider must take reasonable steps to ensure that there won't be abuse. And secondly, for the healthcare professional engaging in such an act, that this may amount to a professional misconduct, and the relevant professional boards or the councils may impose sanctions. And that's point number 2. Point number 3, after accessing the record, whether another breach will be committed, that depends on what act we're talking about, whether the professional is selling the data or whatever. That's another matter about the pursuing liabilities. Well, you're talking about other offenses, professional misconduct. What about this bill? This bill allows disqualification of the HCP. What about the healthcare professional if he breaches this overseas? That depends on the acts. When we come to clauses 41 to 46 on criminal offenses, we can then discuss whether these would constitute offenses. Well, in short, this bill is mainly about regulating healthcare providers, not healthcare professionals or doctors in the HCP. Is that correct? Say if something goes wrong, then the punishment would be for the HCP to become disqualified and no access would no longer be possible. Well, we have not come to criminal offenses yet. I think there may be other offenses. So can you briefly tell us, let's say if a healthcare professional in an HCP who breaches the law, honestly, I don't think there is a difference whether the offense is committed in Hong Kong or outside, according to your bill. Well, let's say if there is a breach, then of course I will take follow-up action on the HCP, because one of the employees in the HCP has committed a breach or contravention. Then I will go after the HCP. I may issue warning letters. I may suspend or even revoke the registration. This is what we can do under this bill. Next, Mr. Eleanor. Chairman, my understanding is that in relation to this e-health record sharing system, the key is about protecting the HCR's data, and it's actually in the hands of the HCR at the time of registration.
At
the time of registration, the commissioner is responsible for registration. So let's imagine this scenario. Say somebody goes to Shanghai and all of a sudden he goes under in a coma and he's sent to Shanghai #1 People's Hospital, and fortunately the patient, or may I use the formal terminology, the healthcare recipient had has a daughter coming along, and the daughter is therefore a close relative who can make a decision for her father. So even in the absence of a doctor in Baptist Hospital, as the daughter is an SDM, a substitute decision maker, she can ask for data access. Now, if it so happens that a doctor from the Baptist Hospital is also in that trip, then that would be easy. Even, well, if even the daughter is not there, if that person is a lone traveler, then is it the case that according to clause 3 of the bill, subclause 4, say if the persons listed in A to F are not present, and then the healthcare provider, in the absence of the persons listed there, which is responsible for giving treatment to the HCR, may make this decision at the relevant time. So ultimately, if you want to have access of the data overseas, you must go after one of these channels. That is to say, either consent has been given, either there is a close relative in a trip, or either you approach a doctor who has been seeing this patient in Hong Kong to make this decision. Because if you ask the Shanghai hospital, they need to get an access code. No, without that computer notebook, the hospital has no access at all. The hospital would need to ring the doctor for the data to be sent. So in that case, I think there is adequate protection. If you want to strike a balance between the safety of the HCR and its data privacy, it seems there is a balance here. Well, first of all, I think Mr. Chan can say whether your understanding is the same as mine. Now, I have a number of questions. Now, in Annex A of the administration's paper, under healthcare recipient, it is now proposed that the wording in Hong Kong will be added. And I think this is the unnecessary straitjacket, because the healthcare recipient can, in the Shanghai hospital through himself or the substitute decision maker, give consent to the healthcare professionals in Shanghai to access his e-record. So the additional words in Hong Kong will pose an extra hurdle. Now, in other situations, I agree that the wording should be deleted. Even for clause 17, service location in Hong Kong, this addition is okay. But my question is, why is this added to the healthcare recipient's definition as well? My next question is about section 33 of the PDPO. Of course, this has not taken effect yet, but I understand the legal advisor's point as well, because for section 33C, it says that
表格添嘅，即係喺我睇緊英文版第5版咧有個表格嘅。
And I'm reading from page 5 of the English version, the form.
嗰個香港嘅即係醫護接受者，佢
So let's imagine for the HCR hospitalized in Shanghai, there was no way for this patient to sign this consent form. So I need to make it clear with the commissioner.
一個系統嘅。
If we are to enact the bill with such a sound system, with strict requirements to facilitate rescue in Shanghai, then Section 33(2)(c) should not form a barrier. In other words, we should deem that a written consent under 33(2)(c) has been given, or we say that exempt data made available from Section 33(2), because, as I have said, written consent will not be possible for somebody who is a Hong Kong HCP, lying unconscious, waiting to be saved in Shanghai. Maybe Mr. Chen can try to answer, and then perhaps we'll have to await the Commissioner of Privacy. Well, all lawmakers would think that the bill should be such that we need to strike a balance between privacy concern as well as timely medical treatment to the HCP. Mr. Chen? Thank you, Mr. Chairman. Thank you, Mr. Leung. First of all, let me talk about your hypothetical case of somebody waiting to be saved in Shanghai First Hospital. According to our bill, this hospital in Shanghai is not qualified to get registered as a HCP because the service location is in Shanghai. Even if we have a Hong Kong citizen encountering a traffic accident in Shanghai, if it so happens that he's to be lucky to have a Hong Kong doctor with him and who has got with him a accredited computer, then it will be fine. But usually that won't happen. Usually the traffic accident victim will be admitted to Shanghai Hospital immediately. That Shanghai Hospital is not an HCP under the bill, so their professionals will not be available, will not have a password available, will not be able to join the system. Even if the traffic accident victim is conscious, he can't get hold of the data. Now, if it is said that it is an emergency case and his data is needed urgently, then what you can do is that a medical doctor in Shanghai should call someone in Hong Kong to ask for the data. As has been pointed out, we have to confirm whether this is indeed a PR doctor in Shanghai, whether there was indeed a traffic accident. Now, in the case of the substitute decision maker, I don't think it will come relevant because only under certain circumstances a family member may make a decision on behalf of the data subject to allow a particular hospital to have the data. You can't authorize Shanghai First Hospital because it is not on the list of HCP. So SDM doesn't come into play here. Now we are proposing a revision. Healthcare activity performed in Hong Kong. We've taken on board Dr. Leung's proposal. So we are taking out the words in Hong Kong under healthcare. But then for healthcare recipient, we are adding the words in Hong Kong. This is because the original definition is that healthcare recipient means an individual for whom healthcare has been performed, etc., etc. And healthcare has been defined as an activity performed in Hong Kong. So when we take out in Hong Kong from the definition of healthcare, so for healthcare recipient, we want to know who will be eligible. He must be somebody who has had healthcare performed on him or likely to be performed on him. If this is a person who spent his whole life in Canada, in India, in Shanghai, I don't think we should make it possible for somebody who has been spending his whole life in Canada, India, or Shanghai, and for him to get registered as a healthcare recipient. What is meant by is likely to be performed. We want to define what's meant who's meant by healthcare recipient. We may have a patient who's still having an ongoing treatment, or we have a healthy person. We may have a child. So it's a matter of past, present, future. Yes, somebody who's likely to commence a healthcare program. In other words, we want somebody, we want the citizens to get registered since childbirth, so as to have comprehensive data. Even a visitor can qualify, but then he must be somebody who has been on whom healthcare has been performed or is likely to be performed. Mr. Ellen Leung, yes, I come to understand it. For the scenario that I outlined, Shanghai First Hospital won't, as a result of the definition of healthcare recipient as revised by adding in Hong Kong, be affected in its positioning. I'm grateful to Mr. Chen for his explanation. He has answered my question. When I first asked the question, I think there was a blind spot. Now you're giving a password to your doctors, and then together with a special computer. Currently, this is not the same. Even as of now, I think it's the same. Is it so? It's a password plus a USB. And then you just insert the USB into your computer. I think Mr. Chen has resolved my concern. For the case of the SDM, it doesn't appear in my hypothetical case of somebody in Shanghai. Now, Section 33 is not yet effective. For 33(2)(c), I hope it won't constitute as a barrier preventing the healthcare recipient from being saved. Maybe our legal advisor can take up this matter, or will it be something for the government? It's for the government. So the government, are you going to consult the Privacy Commissioner? We mentioned this before. I think the Constitutional Affairs Panel had a discussion of this matter. That is when Section 33 will become effective. I don't think it's a matter of the effective date of Section 33. It's a matter of, like outside of Hong Kong, we have got an eligible person, and he is equipped with his own computer, and in the course of giving health care, he needs to download or he needs to access the data. We want to know whether this will constitute cross-border data transfer or downloading, and under what circumstances will he be exempted. So it will be great if the Privacy Commissioner can give an answer. That is, with the enactment of the bill, will Section 33 or the existing guidance note be incompatible with the bill? Mr. Chairman, first of all, Section 33 is not yet effective. They need to prepare for it. But of course, they have got a guidance note. In the guidance note, it is said that if you can meet one of the following conditions, then you will be fine. So it's a matter of A or B or C or D or E or F. For C, if you want to cite 33(2)(c), then you may want to design a form similar to the one shown there. This is but an example. Even if you can't meet condition C, you can choose from among A, B, D, E, or F. On our part, we've already studied our bill. Even though Section 33 is not yet effective, we don't think that our bill is going to contravene Section 33(2). So, is there anything that we still need to ask the Commissioner? Legal advisor. I have read the guidance note in great details. It is obvious that the guidance note is not specifically for healthcare records. I think probably what they have in mind is commercial entities. I understand that the Privacy Commissioner is well versed with our bill. For our follow-up list, we've said that perhaps the Privacy Commissioner may want to consider the following. That is, look at our bill from the perspective of privacy protection. Dr. Zhang has said that it appears to him that we are giving blanket approval for data to be accessed overseas. So it's a matter of whether we should follow Section 33, that is, the healthcare records should not be transferred overseas unless 33(2) is valid. Probably when the Commissioner wrote the guidance note, it hasn't come across his mind that we have this scenario. We're talking about the same medical doctor where there's a difference between the doctor having access locally or overseas. Well, there are two cases here. First of all, as Chair, you have said, it so happens with a medical doctor, he's overseas, he has the computer with him. He switches on the computer and he would like to have a look of the data. Section 33 will still be applicable. Another scenario is that he would like to give the data to a medical doctor not registered in Hong Kong. For doctors not registered in Hong Kong, then it means that we are not having a registered healthcare professional. Moreover, Section 33, despite it not having come into effect, but then when the personal data privacy ordinance was passed in 1997, Section 33 has always been there. We have got the idea of a safe deposit box. Therefore, we must bear in mind that Section 33 is very important. Otherwise, it would not have been included, despite its not having come into effect. Mr. Chairman, let me repeat that we'll always be following the legal requirements. Section 33 will not be breached, even when it comes into effect one day. The government, and I've heard the Bills Committee, we think that in some circumstances, personal data of patients should be accessible even overseas. Say, for example, a Hong Kong doctor in Canada may need to access the data. Now, I don't think it's advisable for a bill to disallow the transfer. Even as of today, this is being done. This can be done. So for my bill, I don't think anything is contravening the Personal Data Privacy Ordinance. I understand the concern of the legal advisor and that of many members as the Commissioner is preparing for the coming into effect of Section 33. So we want the Commissioner to bear this point in mind.
Yeah. We actually want, under some circumstances, for an HCR overseas to have his record accessed by an eligible HCP or healthcare professional. And this is already happening now, and our interpretation is that we could meet the conditions A, B, C, D, E. So this is allowed. Otherwise, please tell me so. we will be discussing entirely on Section 33 of the PTPO, which is outside the scope of our bill. Perhaps we'll ask the Secretariat to follow up on this issue. Yes, we'll take this on. That is in the process of scrutinizing the bill. The BC has put forward this point, and we would like the Privacy Commissioner to note our viewpoint. And if in future Section 33 takes effect, we hope that this won't pose an obstacle. Just let him do the talking. I think we agree that we should take the lead in this. We should not ask the government to do it. All right, next, Ms. Emily Lau. Also on this point, I think it is very important. And you must give us some information after the meeting, how many times this has been used. And there must be a complex procedure, not just by an email. I have no idea what arrangements we have with mainland hospitals, how many there are. So give us more details as to whether this is operable. And what's important is that at present we do allow some leeway to facilitate the treatment for patients, and I don't want this to be taken away in the future after the bill is passed. And I think this should be clearly spelled out in our submission to the Privacy Commissioner. All right, so after going through this, let's read clause 35 and 35A as well, because you will be scrapping 35 and to be replaced by 35A. So please go through these two as well. Clause 35 states the reasonable steps to be taken to ensure that it will not impair the system. And last time Ms. Lau asked what reasonable steps mean, and in the eyes of the layman, they may not understand what reasonable steps are. So in the future, the healthcare provider will be required to follow our recommendations to take preventive measures. So if you're in a position to publish the code of practice, they could just observe the code of practice instead of the clause 35, because clause 35 is not easily accessible. The words reasonable steps, impairing the security or compromising the integrity of the system may not be easily understood. And having considered this, we agree that clause 35 may not achieve its original purpose, and we can therefore delete clause 35. And that's point number 1. After clause 35, on members' concern over the spirit of need to know, after discussing with members, we agree that we should put in clause 35A to hopefully regulate the healthcare provider and the healthcare professionals in accessing e-health record. And we discussed with the administration as well as the Privacy Commissioner. And this version is acceptable by all parties. So we discussed with the DOJ and the Privacy Commissioner on the wording. So I'll see if members also agree with this version. So clause 35A is in Annex B. If there are no comments, then let's continue. So as mentioned by Chairman last time, pursuant to the new clause 35A, the subheading should also be changed under Division 4. So we make this amendment to better tie in with the spirit of 35A. I don't think there will be any objection in principle. Heading of Division 4 is changed. I don't think there is any comment on that. We still have 10 minutes we could make use of the 10 minutes to scrutinize Clause 36 of Division 4? Mr. Chan. Clause 36 and 37 are technical provisions. Now, we observe the Personal Data Privacy Ordinance, and if there is any departure, we will expressly provide for this exemption. So Clause 36 provides that this part applies to data information that is personal data as defined in Section 2(1) of the Privacy Ordinance. So that's about Clause 36. Clause 37 contains departure from the PDPO. And there are two scenarios. First of all, subsection 2. In the Privacy Ordinance, minor refers to any person below 18, but we have a different threshold. So we are referring to a person below 16 years of age as minors. That's why we have spelled this out in subsection 2. That is 37(2)(c). And the other point is about the word commissioner, because both heads are commissioners. We need to make it clear that as to when we actually refer to the Privacy Commissioner as Commissioner, and that's about 37(3). So these are departures from the PDPO, some technical provisions. Any questions from members? Now, about the minor being referred to as a person below 18 or 16 years of age, will there be any substantive impact? Well, originally, for a minor, the parent of the minor can act as a substitute decision maker. But on reaching 16, the minor could make his own decision. But as for Privacy Ordinance, the minor refers to a person below the age of 16. I have a question on the other provision, 35A3. Now, about complying with the data access request or data correction request under Part 5. The healthcare provider is not, not only can the healthcare professional do that, any person engaging in administrative work can also do that. And I see in clauses 26 and 27, or the section 26 or 27 of the Personal Data Privacy Principles, I wonder if these should also be provided, because Section 26 of the PDPO has to do with deleting unnecessary information, and Section 27 refers to the keeping of records for inspection by the Commissioner. What is the advantage of putting these in Clause 35A? Because I see that for these two tasks, they will probably be taken up by clerical staff instead. So I wonder if this should be included in subsection 3 as well. Now, Chairman, may I first explain to members what 35A3 is about for members' benefit. Now, originally, only the healthcare professional can have access to the health data in the system. However, we imagine this scenario in which there is a data access request or data correction request from a data or from a healthcare recipient. And for clerical staff, they may need to access this data before making photocopies, and we should not entrap them. And therefore, we have this subsection 3, such that under such circumstances, the non-healthcare professional can still have access to the data without breaching or contravening the requirement. And that's the purpose of this provision. And the legal advisor is suggesting that since there are such requirements in the PDPO, we should also make the relevant references in subsection 3. Now, we can go back and review this with my colleague. Now, but these are not just technical. For these provisions, these are requirements on the data users, and one of the subsections is the deletion of unnecessary data, and that after the retention period, this data should be deleted, and we envisage that this will be taken up by the clerical staff instead of a healthcare professional. So we wonder if this should be included. And for section 27, a logbook should be kept for record purposes according to the PDPO. And similarly, if this is not done by a healthcare professional, will this constitute the breach of the privacy law? And should it be included in subsection 3? You can go back and consider this suggestion. It seemed that I once wrote to you and asked about this. Chairman, all right, we can go back and consider it. So the legal advisor is suggesting that apart from data access request or data correction request, there may be other scenarios requiring deletion of data or other tasks that may be carried out by clerical staff, and we would like to give exemption to these circumstances, and we can discuss with the DOJ. If necessary, we can add to this clause. Otherwise, we will explain to members why. I think time is more or less up, but in fact we can allow more questions until all questions have been answered. Dr. Kalau, the data, isn't it in the public system? Shouldn't it be done by the government? Why is it done by the healthcare provider? I mean, for deleting data, for data correction and data deletion, this is of course about the PDPO, but can this be applied to your system? Can you delete data not provided by the healthcare provider? Yes, is deletion or correction possible? I'll ask Ms. Lee to answer your question. 35A is about data access request or data correction request, because it is possible that this will be undertaken by the healthcare provider, and the administrative staff may access the data to accede to these requests. That is why for 35A3, this provision is proposed by the Privacy Commissioner. As for section 27 and 26 and 27 of the PDPO, that is about deletion of data in system. For example, after a patient or somebody withdraws from the system, the data should be deleted, and also for as for how long the data should be kept in the system, there are provisions that the Commissioner is required to keep such a logbook. And it is also mentioned in our bill the obligations and liabilities of the Commissioner for the operation of the system. And there are no stipulations that these tasks should be undertaken by the healthcare professionals. So there are provisions empowering the Commissioner of the EHR system to handle such data for the purpose of the system's operation. So our view is that as for sections 26 and 27, we don't need to expressly provide for an exemption because this is not about a restriction on healthcare professionals, but for the obligations to be fulfilled by the Commissioner for the purpose of the system's operation. And there are similar empowering provisions in the bill already. Dr. Lau. Dr. Leung, a data access request. But the data is in the Commissioner system. And according to the PDPO, can he make this request to access data in the EHR system? I mean, the data is in the system, and of course, the HCR can give consent. But can the patient make this data access request according to the PDPO?
Do you understand my question? Say the data, had it been within a hospital's system, then a patient may invoke the privacy ordinance to ask for the data or to ask for correction of the data. But in this case, we're talking about data kept by the Commissioner of the EHRSS. So if the patient would like to seek access or if he would like to seek correction, I think the request should have been directed to the Commissioner rather than the HCP in accordance with the privacy law. Am I right? Generally speaking, if a data subject would like to have a health record gathering information about his visits to different doctors and different hospitals, then of course he has to put the request to the Commissioner because only the Commissioner will have the data across doctors and hospitals. Now, if the patient would like to have data from a specific doctor, say for example he would like to find out whether his name or address is correct or not, he can still make a request to the HCP, but then probably in most cases a patient would like to get a full picture. So generally speaking, it's more likely that the request will be put to the Commissioner. But we don't rule out the possibility that the request is for something more specific so that the patient can find out whether the data given to a HCP is correct. Therefore, we still need 35A bracket 3. As to the request to correct data, other than name and address, there may also be a record concerning the health status. And this information will come from individual HCPs. Say, for example, HCR may get information from the Commissioner, and then he finds out that a particular record kept by an HCP may not be correct. So we have to get the HCP providing the information to correct the data. And then the HCP may therefore need to deal with requests to correct data. Therefore, it is necessary to have this particular provision to take care of such a scenario. All right. It's a bit tricky. Legal advisor, something to add? No? All right. 35A. Any other questions? Dr. Chen, I've come across certain cases in which the patient wasn't happy with the diagnosis of a particular HCP. Say, for example, maybe the diagnosis is a minor case of emotional disorder or psychiatric disorder, and therefore the data subject may request to have the record rectified. I want to know about the process. Well, to be frank, sometimes if I may have a particular disease, I don't like it to appear in my record. I may want to ask the doctor to remove the information. Can this be done? I think you must have certain principles to follow as to what should be permitted or not. I think this may happen any time. A patient may appear before a doctor and ask for high blood pressure, etc., or the names of particular diseases will be deleted from his record. The HCP has to make a judgment. He may agree and refuse to delete. Probably the HCP would not agree because it is a matter of professional judgment. He can put it on record that he cannot agree with the request to correct the data. In this case, the interests of both parties will be protected. A record of the request to correct. On the other hand, a record of the refusal to rectify the record. Dr. Zhang, would it be fine? Yes, I understand. Would it be accessible to others? And this is likely to give rise to controversies. Well, someone may ask for a diagnosis or record to be corrected and the HCP doesn't agree. Now the patient may also want to ask for the record of the record be deleted. Will this be deleted? Can it be deleted? Say, for example, I'm a hospital. I want access to your request to delete it. When others read the record, then he'll be aware of what has happened. There will be a footnote. I call it a log. The log can never be deleted. Say, for example, Dr. Wong would not agree to delete my record. Now, can I ask Dr. Zhang to delete what Dr. Wong has recorded? This can't be done, right? Dr. Wong? Thank you, Dr. Zhang, for your question. According to the Personal Data Privacy Ordinance, there is a clear provision as to how you can reject a request to correct data. You need to notify the data subject of your refusal, and this has to be included in the record so that other data users can be aware that part of the record has not got the agreement of the patient, but the record will still be kept and there is a reason for it. In the case of a health record, indeed, there is a justification. Now, for other data users, for other medical doctors, I think it's all the more necessary to allow others to see that there has been a disagreement, and they need to exercise great care to confirm. We are following the privacy law, and I think our suggestion is right. Any follow-up, Dr. Zhang? No? Dr. Leung? I want to clarify one point. Under the privacy law, usually it is assumed that the data user is also the owner of the data. Data user. Well, in this case, it appears that the office of the commissioner will be the data user. The healthcare provider has the records, and it is also a user. Yes, there is the record, but then it isn't kept with the HCP. It's kept with the commissioner's database. will the HCP itself has a record and then the record will be shared? So the HCP will have some data. I'm talking about data not kept by the HCP, and the data is stored in the government's system. So will the hospital be regarded as a data user? If the hospital is not the data user, then it is not its responsibility to correct the data. I think we have to look up the ordinance. Will it be a data user according to the privacy law, because the records are not kept with the hospital but rather with the hospital, with the government? We have had many rounds of discussion with the privacy commissioner. I'm not the medical doctor, so I've asked whether I should or should not be regarded as a data user. We've been told that the operator of the system and also institutions participating in the system are all data users. All right, point taken. All right. For 35A, any other questions? If not, in other words, we will be continuing with our cross-by-cross scrutiny next time, and we will carry on with 36. No, we've completed 36 and 37, so we should start with cross 38. All right, thank you. In this case, meeting adjourned. Thank you.